Welcome to the Critical Care Obstetrics podcast. My name is Suzanne McMurtry Baird, the Nursing Director at Clinical Concepts in Obstetrics. I'm joined today with my partner, Julie Arafeh, our Simulation Director at Clinical Concepts in Obstetrics. In this podcast, we are going to discuss obstetric unit scope of service. I'll say that again, the scope of service. And everybody's probably sitting there thinking, what is a scope of services? So if you've heard us talk before, you know we talk a lot about this, and we thought we better explain what we're talking about. So here we go with that explanation. First off, a scope of services provides you a foundation for care in your unit. So each unit is going to have a different scope of services based upon their clinical resources and their capabilities of care. And when you think about it, if you know those two, like what type of patients we're going to be caring for in our unit and the ones that we're going to transfer out or transport out, then you can then base all of your training that you need on those patient populations that you're going to keep. So instead of training for everything, you're really just training for those patients you're going to keep. The other ones, you're about stabilization and then transporting or transferring them off the unit. So when you're applying a scope of services, you can really apply this to benefit patients and clinicians. And I want to think about the NICU for a minute. Think about the NICU. They have very defined scope of services for each level of neonatal care. And even though ours maternal levels of care give you some ranges, okay, there are no specific definitions for level 1, 2, 3, and 4. Okay. They just give you, these are the types of patients that you might see. But in the neonatal ICU world, they are specific. And there are no discussions about whether you will manage a neonate that is outside of your scope. They're very clearly defined. And Julie and I've seen that work really well in a neonatal ICU setting. You know, imagine that you've got you're in a neonatal ICU level 1 or 2, and you have a very sick or very preterm infant that is going to require mechanical ventilation for prolonged period of time, or services that are outside of the scope that you can provide. That neonate is not staying in that neonatal ICU. And there are no discussions on the weekend or the night shift about, hey, you know, I feel really comfortable managing that. I did that back in residency or my fellowship or what have you. It is, that baby's gone. They're out the door.
And, you know, not only that, not only is it very clear when you have a baby you're going to keep or you're not going to keep, but it's also very clear where that baby's going to go. So I know that there may be times that your referral hospital is busy. They have a whole system figured out about where that baby can go based on that baby's needs, what type of services that baby needs, for how long they estimate it might be. And they know exactly where they can send that baby. They know exactly what hospital has that capability to care for that particular baby if their referral center is full. So I agree. It's very clear, it's very concrete, and everybody knows what the scope of service is. There is no discussion about whether a baby stays, whether a baby goes.
And we've seen clinical example over and over again where that scope of service in obstetrics can be breached, in other words. So, example, you're a women's hospital, but you're a a level 3 women's hospital and you don't have GYN patients that are inpatient. Maybe you do some outpatient GYN, but you never have adult GYN patients or gyn-onc patients. And just as an example, you know, one of those patients, a gyn-onc patient at age 66, walks into your OB triage, and what are you going to do? She's 66, she's complaining of chest pain and abdominal pain, and she has stage 4 ovarian cancer. And you don't even have a gyn-onc on staff and or the capabilities of caring for this patient, but she's in your OB triage or in your OB-ED. She's clearly outside of your scope of services. So how are you going to manage that patient? How are you going to transfer her out of your system into another system? So I hope that that makes it clear kind of what a scope of service is, and how it could be violated also if you're an OB patient. So let's say if you have a scope of service that's outside in an OB patient, an example of that I've heard before is this patient had mitral stenosis. There is no cardiologist that will see obstetric patients in that system. And this mitral stenosis patient shows up and is going to be laboring there. You know, maybe the nurses haven't been trained to ECG monitoring. Maybe they have no education or skill set to manage that patient in labor. That is something that everybody should recognize. This patient is outside of our scope. But what we hear too frequently is, well, we had one of those and everything went great. Thank goodness. Nothing happened. And luck is not a plan, right, Julie?
Exactly. It's not a plan, at least not a good plan for a patient.
Yeah. So again, you can use this to the benefit of your patients, but also all clinicians can use the scope of service to drive their clinical practices and know those patients that you can take care of. The other thing that I want to point out is scope of services is about number one, and that's patient safety. If you think about any initiative or any kind of policy or practice initiative that you have in your unit, really the patient should be the center of that discussion. How is the care that we provide this patient? How are we going to optimize patient safety? And if she is outside of our scope, then you're really jeopardizing or potentially jeopardizing patient safety by keeping that patient there. And you have to ask yourself, am I prepared to even take care of this patient?
Mhm.
So once that scope is defined, it really again drives all your clinical initiatives and your education so that you can best care for that patient. So what I wanted to do next is to kind of examine some kind of issues and have you really think back and reflect on what your unit scope of service would be for these different scenarios and talk about and make you think, how would we care for this patient at our hospital? Because we've got to have a plan. Everybody has to plan. I don't care what level of maternal care you have, everybody has to have a plan. And many of these plans will fit into these scenarios will fit into one of your units, or you'll be able to relate. So I'll start with one scenario. Patient comes into the OB triage or your OB emergency department complaining of severe nausea and vomiting at 32 weeks estimated gestational age. She is a type 1 diabetic and has not taken her insulin today since she hasn't been eating. She thought, I should probably not take my insulin since I'm not eating anything. So she's a type 1 diabetic, remember. That should be your key red flag. You check her blood glucose, and it comes back at 265 for your point of care testing. You take vital signs. Her vital signs are 90 over 55. Heart rate is 122. She's breathing 26 times a minute, and her pulse oximetry value is 95%. So, based upon our vital signs are vital, I'm automatically recognizing that her diastolic blood pressure is low, her heart rate is high, her respiratory rate is high, and her pulse oximetry value is right at the cutoff before we're going to start implementing some oxygenation, because that is right on the tipping point of being abnormal. So an IV is started and a 500 milliliter IV fluid bolus is given. And then some labs are done. So additional labs besides that point of care testing done. Once you get to her labs back and based upon her clinical picture, she's diagnosed with DKA. So my first question about this scenario is this patient within your scope of services? Number two, do you have a protocol for DKA management in pregnancy? And number three, who is managing this patient? And these are three common questions that come up every time a patient comes in and is diagnosed with DKA, no matter what maternal level of care hospital you work at. Who's managing her? Should we be managing them? And do we have a protocol to manage? And I'm willing to bet that 95% of you do not have a plan on how you would manage this patient. What do you think, Julie?
Well, I would agree. And how many hospitals have we been to where they're like, well, do we need a protocol for this? Do we need a protocol for that? What do we actually need a protocol for? You can look at your scope of service and based on a very honest estimate, not what you would like to be able to take care of in your hospital, but what you actually have the ability to take care of in your hospital and your unit, that can determine what types of protocols you need. Not only what kind of protocols you need, but how you're going to train your staff.
Right.
Because once you have, I mean, I know from myself when I used to take care of DKA patients, the first few patients I took care of, it was absolutely terrifying. It was terrifying to take care of that patient. And I want you to just stop and think for a minute, what is your cognitive load when you have a DKA patient and you don't take care of DKA very often? So what are the things that you need to help you take care of that patient? You need a protocol. You need that protocol distilled down into a checklist. And then what doesn't fit into the checklist are all of the options that the team has in managing this patient. So what do they do if the patient does not the respiratory has respiratory distress? What do you do if the patient, if you have a fetal monitor tracing that looks awful? So those types of things, if you know what your scope of service is, number one, you write your protocol to that scope of service. We take care of this, we don't go beyond this. If we go beyond this step, if this patient has to be intubated, then where is that patient going in our hospital? Who do you call to get the consult? How do you expedite that? All of that can be in your protocol and can be distilled down into your checklist. It makes it much simpler, much smoother when you're taking care of the patient, that you have all of these things figured out already. As Suzanne said, you have a plan of care that's going to speak to patient safety.
Right. And you're going to feel more comfortable about taking care of that patient. I mean, this is a common scenario. Again, doesn't matter which level of maternal level of care that you work at. Your initial stabilization or management may be a lot shorter than, let's say, a level 3 or 4 center. So a 1 or 2 center may be just that initial stabilization, get ICU involved, transport the patient out to a higher level of care. These patients need MFM involvement. They need MFM to manage their diabetes. They need MFM to manage them in the ICU. They need obstetric services, not just endocrinology. And not every hospital even has inpatient endocrinology. So this is an ongoing thing that you're going to have to address. And you said something about fetal monitoring, Julie, and we know that if you have a patient who is DKA, she has metabolic acidosis, the baby has metabolic acidosis as well. So
Mhm.
you're going to have changes in that fetal monitor strip she's going to have a category 3 strip. So you're going to want to, the first reaction to that fetal monitor strip is, oh, well, now we need to take her back to the OR and do a C-section on this patient who has metabolic acidosis. Then she can then become compromised in the OR as well. So lots of questions around this. Everybody needs to have a plan. So let's move on.
Okay.
And did you have something else, Julie, that you wanted to say?
Well, the only thing that I was going to say is there can be a lot of controversy when you have a fetal tracing that doesn't look good, and you've also got a mom who is sick. And if you have that lined out, like what is going to be your criteria for C-section, what is going to be your criteria emergency C-section, what's going to be your criteria for fetal monitoring or for acting on fetal monitoring, then it's less of a discussion. It's written. This is what our protocol says. This is what our policy is. This is how we're going to manage these patients. We're going to allow mom to recover, allow mom's placenta to recover the baby, and then we'll act on behalf of the baby. So those types of discussions can be shortened and some controversies avoided simply by knowing what your scope of service is and having a protocol that speaks to that scope of service.
Yeah, because these patients are sick. I mean, this patient is sick. Her vital signs are abnormal. She's only going to get sicker. And if you don't know how to do that, then she's only going to get sicker and sicker. And we've seen case after case where you have this DKA patient come in and they're managing her by sliding scale. And it's like, no, no, this patient needs IV insulin, bolused in that first hour, IV fluids because she's hypovolemic. We need to watch her urine output. We need insulin. We need, that's how you're going to correct the metabolic acidosis. She needs sugar added to those lines. I mean, there's a lot that goes into this, and this should be more protocolized than your induction augmentation, as far as I'm concerned. And everybody should know it.
Yeah, I agree. I agree. No matter what hospital we go to, no matter how comfortable or how many patients they see with type 1 diabetes in pregnancy, nobody's comfortable with DKA. Nobody. So having a highly protocolized with checklist, lots of cognitive aids is extremely important to make sure these patients get what they need because it's time sensitive with these patients. If you don't treat them appropriately, they are only going to decompensate very
And the
quickly.
right, and the fetus will too. And I can guarantee you, I've yet to be in an ICU where they have an OB-DKA protocol up there too. So they're not going to be comfortable with an antepartum patient up there with DKA, just like you're not going to be comfortable having a DKA in labor and delivery. So this is how we benefit patients by defining this and outlining the care that they need. So scenario number 2. Patient is 6 weeks postpartum. I picked that date on purpose. Let's say she's 6 and 1. Postpartum and presents to the adult emergency department complaining of shortness of breath and severe fatigue. Question: is this patient within your scope of services? If not, who manages this patient? Another question: is OB consulted on this patient? And does your unit or hospital have an algorithm to follow for the ED versus OB management and when that patient comes back up to OB or when OB is consulted. This scenario is very common, and we see this scenario often. And there's a lot of discussion right now because a lot of morbidity and mortality occurs in that postpartum period. And from an OB perspective, a lot of times it's like, oh no, man, she's 6 weeks postpartum. That's our cutoff. We don't ever see anybody. And anyway, she's complaining of shortness of breath. We don't deal with that up here. Doesn't have to do with her OB incision or her episiotomy or her uterus. Then we don't see that patient. What do you think? I mean, what does your unit do? I mean, this happens all the time. Julie, do you have any kind of comments on that one? I mean, because we see that a lot.
We see it a lot. And I think for our listeners who work in emergency room or who work in a smaller hospital where they're floating around to different units, you may or may not even have an OB unit in your hospital anymore. There are, I think, now over 40% of hospitals in the US that no longer have an OB unit. So for them, it's not only was OB consulted, like how do we consult and how do we know how urgent the consult is needed? Because if you're talking about someone who's in another hospital or in another county, it gets even more complicated. And it's even more important that the emergency room understand what their plan of care is going to be and who's going to go where. It's helpful if you have an OB unit in your hospital because then you should be having OB consult with these types of patients for
Right. And
exactly
they
the
may not,
reasons Suzanne said.
right. And they may not come to your unit, but you need to be involved in the care. I mean, because I'm thinking a 6 weeks postpartum patient who's had progressive shortness of breath and is fatigued, I'm thinking cardiomyopathy.
Yes.
So peripartum cardiomyopathy is a huge possibility and a huge killer of women
Yes.
in the postpartum period. So this is a scenario that you're going to see over and over and over again, and we have to have a plan. And we recommend having an algorithm, that is worked out between the ED and the OB. What patients are you going to see in OB and what patients are going to stay in the ED? And how do you manage those if the patient is still pregnant, even? So I think it's important. And we've seen all kinds of patients, and I know the response from OB, and I've been the charge nurse many, many times. And I'm like, why is that patient coming up to OB? And really, if they're antepartum, then you really need to deal with it. But if they're postpartum, this discussion shouldn't be happening in the middle of the night. And depending upon your bed census or your availability, OB needs to be involved with this patient.
And I think it's this case is extremely relevant for scope of service
Yep.
because a cardiac patient is not a cardiac patient is not a cardiac patient. And I think you can be lulled into a false sense of security by thinking, oh, we have everything. We've had cardiac patients before. Well, uh, the scope of service needs to be specific. And we recommend all the time that you use the World Health Organization modified cardiac classification system and get that specific. We will keep this patient. We don't have the capability to keep that patient. And be fully aware that there are criteria out there, particularly for congenital heart disease. If you look up the congenital heart disease guidelines that are that are put forth by cardiology, they are very specific down to you have to have this professional here this many hours or capable to do this test in this amount of time. You have to have these types of providers. They have to have this type of education. You have to have an anesthesiologist who is prepared in this way. It's very, very clear particularly with congenital heart disease, who can stay in a particular hospital and who can't. So I would really recommend that you look closely at those classifications of heart disease and pick which ones your hospital is capable of managing, and then determining if your hospital's not capable of managing that level, where is that patient going to go? And it may not even be your typical referral center. It may be a different referral center.
Right, right. And lots of hospitals are very specialized. And I think it's really a big question too for women's hospitals. And we see that a lot. Standalone women's hospitals may or may not have some of the subspecialists that they need to be able to care for certain types of patients. So um, be aware of that and have that plan. It's kind of like we used to say, what keeps you up at night?
Mhm.
Oh, what keeps me up at night is a postpartum patient coming in at 6 weeks postpartum, and we don't have a cardiologist on, and so on and so forth. So have that plan. Okay, last scenario. This one's kind of split into part one and part two. So stay with me. She's 29 weeks estimated gestational age, admitted to the antepartum unit. So I had to get that antepartum group in here because that's a different unit in some hospitals. It may be different care providers. And she's coming in because she has chronic hypertension and they need to manage her blood pressures. And they're also reviewing to see if she has superimposed preeclampsia. So she's had one dose of antenatal steroids, and now she has a blood pressure of 172 over 112. So then the physician orders a dose of labetalol at 20 milligrams IV, and that's given. And 20 minutes later, her blood pressure is 164 over 114, and the patient has a heart rate of 112. So they give a second dose of labetalol of 40 milligrams, and the patient, though, still remains with severe range pressures. So here are my questions. Is this patient within your antepartum unit scope of service? And do you have a protocol for hypertension management in pregnancy? And who is managing this patient? So I know we've talked a lot about protocols for hypertension, and I think from my experience, most of y'all have those and you're really getting on, giving the first round of medications, and nurses can go ahead and implement that without a physician order in some hospitals. So everybody's pretty aware of that. But my question on this patient is, does this patient stay on antepartum or does she go somewhere else? And I think that we, again, do a pretty good job at those first line medications. And then we're kind of like, well, we got to the bottom of the algorithm. Now what do we do with them? Right. So this patient is transferred to labor and delivery, where she remains hypertensive with severe range blood pressures. The hypertension protocol, which was again previously initiated, it continues. So they go through those first round medications of labetalol. Now they've switched this patient to hydralazine, and the patient continues to have severe range blood pressures and now is complaining of shortness of breath. So, is this patient within your labor and delivery unit scope of services? And again, who is managing the patient? The question there is, does MFM get involved? Are you trained to manage this patient? What's next? What's the next step? I can tell you what it shouldn't be, and that shouldn't be, well, let's just take her to the OR and do a C-section on her. You have to say these words at this point. This patient is critically ill. And you repeat that. It should be like going through your mind. This patient is critically ill. She is compromised. We need a plan. I need the right team to the bedside in a timely manner. I cannot manage this patient on my own. And can our unit manage this patient? Julie, I know you probably want to say something about checklist and planning for these patients too.
Definitely. I mean, one of the things that is so wonderful about a scope of service, if you are doing any kind of education planning, is it really sets a roadmap for you as to what you're going to educate staff on and what you're going to practice. So, having a scope of service allows you, particularly with these types of patients that are hemodynamically unstable, you're not quite sure where they're going to go in your unit or who you have to consult with in your hospital. So let's just take this patient for example. You get to this point down the algorithm, you can easily have a point there in your checklist that says if you've exhausted or you're down to this level with your antihypertensives, you're going to call an MFM. You don't have an MFM, you're going to call your referral hospital MFM. However, your hospital has set this up, you have the ability to train to that particular situation so that everyone knows what happens with the patient. And I want to say too, if you don't have an antepartum unit and now this patient is out in postpartum, you can also put criteria in there that says this patient requires this level of care. If postpartum cannot meet this level of care, then that's another criteria for moving the patient back to labor and delivery. Because so many times I hear, well, that patient's delivered, we're not going to take her anymore. That postpartum patient may be the sickest patient on your unit. A lot of bad things happen in postpartum, and within the first 48 hours, they can happen. So, not only does the scope of service define who you're going to keep, it defines where they're going to go so that there's not this fight between postpartum and labor and delivery about where this patient's going to go. This patient requires this level of care. Therefore, either someone comes and provides that care at the bedside or the patient moves.
Right. And if you don't have an MFM, then you would call in possibly the hospitalist or the ICU physician at your hospital, but you got to know that. I mean, ahead of time and not try to figure that out or talk that provider into coming to the bedside. This particular scenario is now what we'd call an RRT because the patient's critically ill in a unit that is not trained to manage this patient. She needs an arterial line that requires ICU admission, those types of things. She needs a second line vasodilator, and that requires ICU admission. So it's not like these patients are managed on a general care unit.
Yeah.
And this patient's still antepartum too. So we need to stabilize a mom to stabilize a baby, and the OR is not the place to do it.
Well,
So,
and you bring up a great point because I have experienced this myself, and as I'm sure you have. You pick up the phone and you're like, "We're supposed to get an ICU consult on this patient," and ICU's like, "What? Wait a minute, I didn't know about that." But if you have the scope of service, again, as an educator or as someone who is planning for education for the unit, you can determine very quickly what units you need to work with to do joint education so that everyone is aware that, hey, you might be getting a call from OB about this particular type of patient. This is somebody we take on our unit. And then on this unit, when we have this patient transferring to our unit, this is the support we can expect from OB. These are the types of medications we are need to be giving, how we're going to be giving them, and it's just a much smoother transition from unit care from one care of one unit to another unit.
yeah. And one last point I want to make is as you're outlining this, to make sure you include all your key stakeholders. So I'm including the ICU, I'm including the ED in scenario two. I'm including cardiology in scenario 2. I'm including those people so they have a understanding up front that these are the type of patients that we're taking care of at this hospital. We're a level 3, we're a level 4, we're level 2, 1, whatever it is. These are our patients. These are our people. And we need to plan care for them and how we're going to stabilize and transport or transfer, or how we're going to care for those patients in our unit or in our adult ICU or in our ED. So that's kind of wrapping it up. I hope that's helped you think about your scope of services and remember, all you probably have a scope of services, all your units probably do, is just hidden in your paperwork somewhere in some office. But it's key that the bedside providers have to understand this, because that's who's actually taking care of the patient, and they're the ones who need to understand it. So it's not a discussion in the middle of the night. And that also provides you with, um, if you have a concern outside of that, let's say, that you'll know what to do. The plan may be, I need to escalate my concern because I'm not comfortable taking care of this patient. And that's perfectly acceptable. And we have a podcast on chain of command or escalation of concern, but
Mhm.
that's where that falls in there too, because you're not doing yourself any favors or the patient first, remember, then you need to escalate that care and that concern. So,
I also want to just highlight that there can be a lot of discussion and differing of opinion at the bedside. I want this patient admitted here, and the nurse is going, "No, we can't." Well, yes, you can. She's an induction. I want this patient admitted on this unit. Or I want this patient to stay on the unit because she's my patient. I promised the patient I would deliver, be there for the delivery. And what the scope of service does is it just takes all of that discussion and stops it, because you have a document in your hands, and that scope of service needs to be clearly and cleanly accessible to everyone on the unit. If there is a problem with a patient not meeting criteria to be admitted to the unit, then you can go back to that provider as a nurse and say, "This is our scope of service, and you can speak to this person if you have an objection to that." So you take all of that discussion and disagreement out of your work life and you put it back where it belongs, to people who are making decisions about what your capability is and how you're going to care for these patients. So I,
right.
I think that's very important, because I know a lot of nurses get into battles or discussions about who's going to be on the unit and who's not, and what patients they're going to take or not. This should help take care of some of those issues.
Well, it takes so much of the emotion out of it too, and the feeling about it, because it's not about me, it's not about you, it's about the patient
Mhm.
and what's best for the patient. So, and we can do that together, if we have a plan and understand our capabilities and our scope, then we can do that with less emotion and heart and feeling, because you're just doing what's best for the patient. So, well, thank y'all for listening to this podcast. Don't forget to subscribe and leave us a review. We have a lot of discussion in our Critical Care Obstetrics Academy, for example, on this topic. So, for example, we discuss invasive hemodynamic monitoring and critical care medications and what requirements a unit must have in place to take care of these patients. So, a lot of that is covered in our academy. So, check that out on our website at www.clinicalconceptsnob.com. And then you can also follow us on our Facebook page, Clinical Concepts in Obstetrics, on X at OB Critical Care, and on Instagram at Critical Care OB. And then also you can email us or send us a direct message for suggestions on future podcasts. Thanks so much again, and we'll talk soon.
This podcast was produced by Austin Baird. Are you looking to create a podcast? Please email me at podcastnashville@gmail.com. That is podcastnashville@gmail.com.